for our care home colleagues. So that's all of you. So yeah, we're just so full of admiration. And again, thank you for your time. Sandra.
All right, so that means you've got a doctor in the house. So all doctory questions, please fire at Hein. He's up to the task. Okay. It's good to be here and it's good to see everyone. Hopefully by the end of today, we will have an idea of what Restore2 is, if you don't already know. And of course, we'll be clearer on the COVID oximetry at home work stream as well. This is just an introductory session. We're not going to train you on Restore2 here. This is just to kind of give you an idea of, this is what we are offering in terms of training. Because of course, the Academic Health Science Network is offering free Restore2 training to all care homes in our region, and people have been participating. So we're kind of wanting to, get everyone to be aware of it so that you can get your staff signed up on it if you already haven't. And if you have, and you have some people who are still not signed up, then you can encourage them to sign up. So that's the idea. I'm going to try and share my screen. Let's hope I can find. Okay. It's just a couple of slides. And of course, the idea is that we'll be able to generate discussions and get us all to, kind of see it. Okay, so that's who we are. I am Sandra Akintola, and I work with Hein as one of the senior project managers at the Academic Health Science Network, and I lead on the training as well. Okay, so Restore2, what is it? It's a tool that was actually developed in our region here. It's a tool that was developed by West Hampshire CCG and the Wessex Patient Safety Collaborative. This is a tool that was developed specifically for yourselves, people within the care and nursing home sector, as well as domiciliary care. So it's something that is being used out in the community, and is a tool used primarily to be able to enable staff to recognize physical deterioration in the people we are looking after, the people we are supporting out in the community, whether that be in a residential, in a nursing home setting, learning disability specific setting, dementia specific settings, or even people in their own homes or supported livings as well. So it's a tool that allows our staff and carers to be able to quickly recognize when somebody may be becoming unwell or when they are getting worse, and to be able to escalate their concerns appropriately in order to be able to get the right care at the right time for that person. So, and this is a tool that has been tried and tested. It's a tool that has also won awards, kind of all around. And it's a tool that is being recommended by a lot of organizations, national bodies, as well as individual bodies as well. I mean, CQC has actually gone ahead to recognize it as well and saying, look, we think this tool is a good thing, for every one of us in the setting. So it's actually very good. All right. So what
Sandra,
is this tool? Oh,
can I just quickly add, as a GP,
okay,
it's really helpful when we get called up. So if you're worried about one of your residents, and you go through this tool, and it's literally a minute or two, it's not like loads and loads of work, but if you present the worry and some OBS and maybe a new score, it really helps us like prioritize and know how we can support you better. Sorry, Sandra, over to you.
No, that's fine. I was going to get you to talk later. So what is the tool? Why the tool? Really? So we've seen what the tool is, but why? It's all around deterioration. When this was developed, there was so much concerns around carers missing out, people who might have sepsis and some other conditions, which obviously could lead to people suffering unnecessarily, sometimes people even dying when such could have been prevented. And it was all about the fact that people were recognizing deterioration late. So we're not saying people, we're not saying carers don't know when somebody is unwell. But what was found out, or what the evidence was suggesting, was that There were times when by the time people got to hospital, it was quite late, and it would have been really, kind of beneficial if the carers had recognized quicker when this person was unwell. So that was where the tool was coming from. Is that thing that allows people to be able to say, that thing I'm thinking of, I kind of look at this person and I'm like, I'm just like, I don't know what's going on, but I'm worried. And they can act on that gut feeling. They can just go and say, I'm not quite sure, but let's just get this checked out, rather than sitting on it and saying, oh, maybe it's just one of those things. Maybe they're just, under the weather. So this tool allows people to be able to spot very quickly when somebody is unwell and raise the alert and raise the concern. And of course, how does the tool work? It has some components to it. There's about 4 components, or 4 to 5 components, depending on which of the tools you are using, and I'll explain that later. So Restore2 has, the 5 key components, we call them. First one being the soft signs. That's pretty much what everybody would probably know about. So I see somebody, I see some symptoms, I see them coughing, refusing their food, being lethargic, confused, more than normal, shivering, all those things, or sometimes they're not things you see, but they're things you kind of, you're just suspecting. You're just, that gut feeling. I mean, I keep saying that every one of us who work in the healthcare industry, we've got the sixth sense. You can just sense when, no, I know this person. They don't look themselves. They're not talking like themselves. They're not feeling like themselves. So those soft signs. So it allows people to actually recognize those soft signs. And then, of course, we know what is normal for this resident. And uh, carers obviously in care home settings and domiciliary care as well tend to be really good at this. So it's going from what is normal for this person and how have we seen a change. Why am I feeling this way about this person, or what is this person telling me that is kind of out of character for them. So that's a section is there as well, and this includes what their normal news scores might be. News being the National Early Warning Score, which obviously some of us would have heard of it before. Some of us might be using it, and those who are not using it hopefully will find out how to use it. This is the standardized assessment tool that kind of forms like a common language across all of healthcare, which gives us an indication of how unwell somebody might be. There are times when we know this person is unwell, we just don't know how bad things are. The National Early Warning Score tool allows us to be able to, gauge how this might be. And we speak that language, and everyone across the healthcare continuum obviously understands. By the time I'm saying somebody has got a new score of 5 and I'm speaking to a GP, they automatically, have an idea of how bad you are telling me things are, rather than me saying, well, they're really bad, I don't really understand, they're not themselves. That does not really give the other person an idea of how bad things are. But when we use this common language, it seems to suggest to people, okay, this is the person I need to prioritize. This is the one that needs to be seen by me now. This is somebody who needs to be in hospital and not at home. Actually, this person can afford to be at home, and we will treat them. So this tool allows us to do that. And of course, we within what is normal for the resident also, we have the end of life care planning, any advanced care planning, or any treatment escalation plans that the person may already have. Hein, do you want to say anything quickly about that? Or mute? Hein is
Yeah,
mute.
sorry, there you go. Yeah, no, to add to what Sandra said, this is really helpful for us. It's not meant to be more work for you. I think people are doing it already. It's not always in a kind of standardized way, and it can be POC. And certainly using SBAR to communicate. And I know Sandra's going to come on to that in a bit more detail, but I use it. I'm not very good at explaining a situation, and so I take 30 seconds when I'm going to speak to someone to go SBAR and just write a couple of bullet points, and it has just transformed how I speak to people and cut down the amount of time. So this is not some sort of clinician trying to speak to you. I think these things are really important for all of us, because we're all a team at the end of the day.
Yep. Okay, so the other bit, we've talked about the National Early Warning Score. Then there's the escalation pathway. There are times when people know, yes, I need to call somebody. But then, staff on the ground are thinking, who do I call now? Who needs to see this person? So within the Restore2 tool, there is that guide. There is a plan that guides you on who you want to, escalate this person's care to. Who do you want to contact about this person? And this has really been found to be very useful for a lot of places, especially, when there is not a nurse on site. And people are thinking, who do I call now? Do I call my manager? Do I call the GP? Do I call the ambulance? Do I call out of hours? This guides people. And the final one is the structured communication tool, which is the SBAT that Hein has alluded to. This is something that just guides our thinking. I mean, if you're like me, and I mean, obviously, I'm a clinician, by background as well. I'm a nurse, and there are times when you want to kind of escalate your concern. You want to tell somebody you're worried about this person, and you're just all over the place, because you are very, you're human as well. So having your thoughts kind of composed and having that structure really enables staff to be able to give the appropriate information, the need to know information, the key things that would help the person we are contacting to be able to make the right decision for them. And so the SBAR, we actually do practice, using the SBAR when we do the training as well. And people found that really useful. So these are just, this is what the tool looks like. It's just 3 sheets of paper. The front first page has the Restore2, and then the second page is about what is normal, as well as the escalation plan that I spoke about. And then the third and fourth pages are the news chart. It just gives an example of the news chart, which people can photocopy and use. And then, of course, the last 2 pages, the last 2 pages are the SBAD. And we've known occasions when people have just photocopied that SBAD page and stuck it to where their phone is, so that it guides them, in how to communicate their concerns. And what we say to people is, the more you practice, the easier it becomes. By the time we go through the training, people realize that actually we are doing some of it. We're just not doing it in a coordinated way. So it allows people to be able to coordinate their thoughts and helps them. Now, I said there are, there are different versions of the tool. So there is the first set of tools I showed you is the full tool. That's the one that contains the news component and the escalation component. Then there is the Restore2 Mini. This is just an abridged version for homes that probably do not take observations. Homes that either because they don't have staff who are skilled, to take it, or they just don't have the equipment. So sometimes some residential homes will use this, some supported living facilities may use it, and some LD specific services may use it. And this tool is the abridged version. Like I said, it's just the front and back, just one sheet. It's the recognizing of the soft signs and then the communicating your concerns using the SBAD. And the mini tool, actually, we've done a variety of it. So there is a mini tool for domiciliary care users, which just changes the terminology. So instead of saying residential people, your residents or people in your home, it just talks about them as clients, because those are the people they look after. And then there is one for learning disabilities, which takes out the thing around residents and just uses the terminology of persons. Different people wanted something more specific or bespoke to them, so the tools have been adapted. I thought I will share with us what the experience of some places that have used the Restore2, and this is coming from care home managers, and just for you to see what people are saying about it. Obviously, we've got case studies as well, which tells us how the Restore2 has been in practice. Let me play this, but I'm going to have to, because when I do my share screen, let me just quickly stop this, because when I need to do the share screen, I have to put share computer sound and optimize screen. Yep. So they said. I think I'm doing the right thing now. All right. Here we go. This is a very short video, so hopefully it should play. Come on. Oh, go on. Otherwise, I will play you from YouTube.
Hi Sandra, it's Angela. I'm wondering, is it not loading?
Oh, can't you hear me?
No, nothing's happening for the rest.
Oh, sorry. Do you know, I was going to ask if you guys could hear me. It was playing. Okay, let me play it from YouTube. I'll play it directly from YouTube. Oh, poor you. I kept thinking, can you not hear me? Okay, let me play it from YouTube. Well done, Angela. Well done for spotting it. My screen. Yeah, share computer sound. Optimize screen sharing for video clip. Yeah. Let me know when you can hear it.
Have you still got to share your screen as well? Has that got to happen yet?
Hang on. Oh, yeah, you're right. You are absolutely right. Are you seeing anything?
No,
Angela?
Is your file?
My file.
Oh, the file's open on your screen, as it were.
Okay. Oh. Okay, let's go back to. I will. Oh. This normally plays. Oh, come on, behave. This is the best bit of the. This is the best part of the.
Yeah,
it's the best part of.
we're missing,
it's going to happen.
We're missing your finest moment here, Sandra. Come on.
It can't happen. I mean, what a. Can you see anything now?
No.
Okay, let me go back to. So I go back here, share screen.
Yeah.
Oh, my. Okay. Tell me if you can see this.
Yeah, we're back with YouTube now.
Okay, well done. I knew we're getting somewhere. Can you hear the sound?
Yeah, it's working.
Does get looked at by nearly every professional that comes in.
The feedback from the hospitals has been brilliant. They love them, think it's absolutely brilliant. And again, like I said earlier, our doctor's surgery, they now ask us what the score is. So I think from our experience, it's working really well.
It underpins their feelings. Gut feelings go a long way, but when you actually do the Restore2, it gives them the competency. Yeah, actually, I did get that right, and I've got the evidence to back it, so I can move things forwards.
We'd usually do what the GPs will call the basic obs, so the blood pressure, pulse, temperature, SATs for general review anyway. But across the whole team, it's really, if anything, I think it's raised confidence throughout the whole team now because they're documenting it down so usually our senior carer would do our baselines, but sometimes that's not always possible. So across the board now, every member of staff is shown how to do every set of the observations. So every member of the team now takes part in that, and it's really, really good because it's just making everyone feel so much more confident, and everyone knows how to use the Restore tool. It's brilliant.
Soft signs of the Restore2 are, in my opinion, more important than the actual readings themselves.
Okay. Is that because that's that first indicator?
It's those first indicators which start to say, do you know what, something's not quite right.
And we had a lady beforehand, we did the Restore observation, the news score, and reported that to a GP who at the time, this was very early on when we were using Restore, she wasn't overly concerned regarding the result. However, we still weren't happy, so we actually went over and above the GP, and it actually turned out that particular lady did have sepsis and did in the end have to go to hospital. Yeah, that was using her soft signs, because this was a lady that had been with us for about 10 years, and we knew the points of when she was getting poorly, so had those on the front of the form, and it was literally using that to escalate it further, and actually, you know, no, we're not happy with that, so we're going with what this form says, and it actually worked really well. The lady did get treatment and luckily came back home.
For one of my residents who's got advanced COPD, working on the soft signs, even though his new score doesn't change, we now know when we can start rescue medications to keep these people out of hospital. So that's picking up the soft signs and normally stats, which tells us when we need to go in with the antibiotics. On the back of that, he's not been in hospital now for a year, and he was going in every 3 months. Because we could use the Restore2 tool, we could give them all the information. We actually bypassed all the questions from the 111 team, and it went straight to a professional discussion, which means an ambulance was here within 20 minutes to take this particular gentleman to hospital. We are residential, we're not nurses, we haven't got nurses here, so we don't get that straight professional conversations. And it was good to be able to bypass all the ongoing questions which they asked to get things moving faster.
And was that just because you started off with the school and they said, right, we know that needs to go?
I think it's once you start using the Restore2, your whole conversation changes. You're on a much more professional level, and they're starting to respect that.
You didn't say about your gold standard framework and how you use Restore2 with that, and how you got really good feedback.
Well, it does. They work hand in hand. It starts to identify when people are moving down the gold standard scales, especially when you're going between green and yellow. I mean, obviously on blue and red, it's pretty obvious what's going on. But when people are on the slip, it gives you the pre-warning that people are on the slip. So we've got more chance to get things in place before we actually get to crisis point. So it gives us a warning to get the GPs in, to check everything's in place, to get the just in case medications in, to have the district nurses primed, so nobody ever suffers. So we just marry the two together.
Fabulous. All right. Are we back? Ooh, who's this? Hello, Julian Edwards. Julie Edwards, hello. Ooh, you've taken over my screen. Welcome. Okay, so what do you think? What do you think?
Because I've come on late, I'm a bit, yeah, it looks good. I would like to use it.
Good.
Absolutely. Yeah, I would like to give it a try, but because I come on a bit late, I need to know a little bit more. So perhaps you can email me privately or something.
Okay, it's been recorded, so you can go.
Brilliant.
And
brilliant.
Yeah, but,
okay.
Yeah, but it'll be fine.
Lovely.
Yeah, what do you all think? The rest of you, what do you think? Come on, I've been talking for some time now. Unmute and say something, please. Jane, Clifton House, what do you think so far?
Yeah, we've been using, all our staff have now been trained on Restore2, and we've been using it as what is just been discussed in the video that you shown. It does help us to monitor and show signs of when someone is deteriorating. So yeah, I highly recommend it.
Fabulous. Okay, let me just quickly finish.
Sandra, can I come in with just a little pointer?
Yes, please. I'm trying to go back to mine.
The resources are going to be available, aren't they, for people? So when we finish this, we'll be able to send people out information on where they get the training and
yes,
contact.
Yep.
That.
Yep. Actually, yep. I thought it will help for you to. Can you see my screen? Can you see my screen now?
We can. Thanks.
You can. Okay. Yeah. So this is just the slide on the training. So if you go on our website, and I've put the address here, yes, send your staff down that way, and yeah, depending on which of the models you want, whether you want the full training, the full Restore2, or the mini version, or the train the trainer, because we do train staff from the various homes to be trainers. So if you want to roll out the training, internally, we can help your staff to know how to do that, so they can come out and train the trainer.
And thanks, Sandra. And I'm conscious that there are a couple of people who provide home care, so not residential settings on the call.
Yep.
They can look into this as well. And
it's open to everybody. People in domiciliary care can use it. Even, I mean, we've just recently trained carers of people with a learning disability, and some of them are family carers. There are people whose family members have a learning disability, so they can be trained as well. You know, and this is just for you to know that we've got a lot of, you know, homes and a lot of staff being trained now. I mean, currently we have up to 1,000, almost 1,500 that has been trained, and we've trained about 25% of the care homes across this region. So it's really important that you get on it, and there are loads of resources. And this is just a slide on some of the reflections from some of the homes, you know, that we've trained, you know, from Swindon, Bristol, even Derbyshire. Yeah, so something for you to, you know, kind of have a look at. So I thought what we will do now is kind of hand over to Hein to give us a bit about the COVID at home side of things, which I'm sure you are all raring to crack on with. I'm going to share the slides for Hein as well. Okay, where am I? Let's go back here. Yep, that's just something about end of life care. And then, Hein,
Right.
over to you.
Thank you very much. And I'm aware of time, so I'll keep it just to the point. So in parallel with the work that Sandra's been talking around Restore2, which fits with the more general deteriorating patient, because as that video showed, people get sepsis, they get heart failure. There's lots of things that can go wrong with our residents. But obviously one of the key things in this pandemic has been COVID, and I run the COVID virtual ward up in Gloucestershire, and it's been scary watching how a care home, you know, you hear of 1 or 2 cases on Monday, and by Wednesday there's 20 cases and 15 staff members all got COVID, and it just really can, you know, escalate and spiral that quickly. So, you know, again, I'm so full of admiration having spoken to people on the phone and helps, you know, sort out patients in our local care homes. One of the things about COVID, and hopefully you've all heard of this condition called silent hypoxia, and that's why it's important to monitor these patients with a pulse oximeter. But and I've got a case, don't go move yet, Sandra, but in a minute I'll go through a case study with you. But essentially COVID seems to be about a 10 to 2 week condition, and fortunately most people are fine. Some people get sick and then are fine, but there's a smaller cohort of people that aren't fine, and being in a care home setting, whether it's nursing or residential care home, particularly older people, but you know, anyone with some sort of learning disability, long-term condition, BAME background, puts people at higher risk. But basically what silent hypoxia is usually between day 5 and day 10 of your COVID illness. If it's going to happen, your oxygen levels in your blood can drop. And normally, you know, if you run up a flight of stairs or run up Mount Everest, you go, gosh, I feel really breathless, I feel unwell, I need to stop and have a breather. And then your body's physiology would kick in, you'd breathe a bit quicker and you'd catch up. But in COVID, for whatever reason, people don't realize how unwell they are becoming. And so they can have this, that's why it's called silent hypoxia. You don't feel breathless, you don't feel unwell. And you can go on for days like that, and you know, you haven't got enough oxygen, and your levels can drop really low, and then suddenly everything starts going wrong. Your heart starts getting impacted, your kidneys, your brain. And actually, if we'd picked you up, you know, 2, 3, 4 days earlier and gone, oh, we know where this is heading, let's get you into hospital for some oxygen and steroids, we would stop you getting that unwell, and your condition would hopefully get better much quicker. So that's silent hypoxia. Now, this is hugely relevant to you guys in a care home, because I think sometimes we would in Gloucestershire have the virtual ward and we would look after your patients, but in some of the other areas it's much more to do with being over 65, and so they're missing out on a whole cohort of people. But what we've done locally is help the care homes set up their own virtual ward, because essentially what you need to do is to take the person's saturations a couple of times a day, you know, sometime in the morning and sometime in the afternoon. And I guess if they're feeling more unwell at any other time, do their oxygen saturation. And the key numbers to remember are if the oxygen saturation goes below 93, so 92 or below, that person needs to go into hospital and get oxygen and steroids. And this fits with what Sandra was saying around respect forms and end of life planning, because not everyone will want to go into hospital, and actually some people will be at the end of their lives anyway. And so it's important to, have those discussions and involve the residents and their family, and people can change their minds, and that's fine. That's what hospitals are there for. But it's been really helpful at getting the right people into hospital for care, and made a big difference. So as I said, we different services in different areas. I think this has been rolled out across the whole of the UK. But I think in a care home where you've got more of an infrastructure, you could set up your own virtual ward and just do it and act on the numbers. So it's really easy to do. If you just go on to the next slide. So I'll just talk you through a real case example of someone I looked after. Now, this could be so we're talking not nursing homes, because often they've got clinical staff, so we would say they would run their own virtual ward. But this patient could be in a residential home, and this was actually one of my patients, or they could be living at home. So I'll just quickly talk you through what happened. Day one, which was a Saturday, this 57-year-old chap developed a cough and fever. Well, at the moment, what else could that be? That's going to be COVID. Sunday, he had a test. On Monday, the test result came back, and it got sent to him, but it also came to us at Churchdown, where I'm a GP. There's slightly different criteria in different areas. I think in your area, it's that the virtual ward is for over 65. We've done it for any over 50. And anyone who's in a residential care home over aged 18. So, we've got a wider net, but you can do this in your own care setting. I contacted that patient, and we worked out he was in an at-risk group, and therefore at risk of silent hypoxia and getting sick. So I referred him into our virtual ward. We've got a referral form. I safety netted him and said, in the meantime, this might take a day to get back to you and set it all up. If you're feeling unwell, this is what you need to do. And we got him a pulse oximeter. Now, hopefully many of your residential care homes will have a pulse oximeter. And if you haven't, they're really easy to get on Amazon or the CCG, probably lots of them, and can get you some. So make sure you've got those in place. So that all happened on day 3, the Monday. On Tuesday, he got on board onto our platform, which is called Baywater, and they phoned him and got in place and made sure he knew what to do, and he could submit his readings by an app. But in a residential care home, you could just write it on a piece of paper. In a way, it's much easier to do in your setting than it is with people just out in the community. And we recorded his SATs, and they were 95, so that's day 4 now. We follow up these people twice a day, and just through the app, just to get them to submit their data so we can keep an eye on them. And you can do that yourselves in your care home. So just remember what I said about silent hypoxia and when it tends to strike between day 5 and day 10. So actually, bang on cue, day 7, which was a Friday, the chap's morning SAT was 91, which indicated silent hypoxia. We usually say repeat it after 10 minutes and, make sure the hand's warm and all of those things. And it was still low. So what the service then arranged for this person to go into hospital, and locally we've got an agreed pathway with the ambulance service, but I don't know your exact arrangements in BNSSG, but I'd be getting onto 999 and saying, I've gone with COVID, it's silent hypoxia, can you get them into hospital? We then got a thing where we talk to patients, to the hospital on that's a Gloucestershire tool, but you will have your own pathways, but just phone 999 and they'll get that person in. This chap then went in from Friday to Monday, which is 4 days, day 7 to day 10. And they put him on the virtual ward, on the proper COVID ward in the hospital, and they gave him oxygen. So, if your SATs are in their 80s or low 90s and you have oxygen, they go up into the high 90s, hopefully. It really helps all your organs recover. They gave him steroids, which helps reduce the body's inflammatory response to COVID and lets you get better quicker. And he gradually improved over those 3 days. And then day 10, the Monday, they said he's well enough, he can go home. And they did their own bit of remote monitoring, which is what the hospital do, is called the step down ward. And they kept an eye on him from home for another 2 or 3 days. And they could see he was on the road to recovery. And he's done really well. Now, some of these people could get long COVID, and these pathways are being developed locally. I mean, most people get better with time, but it can be like post-viral fatigue and really horrible for some months, and people just feel totally wiped out. But eventually they do all seem to recover. So hopefully that's a quick canter through. You guys have been in the eye of the storm. You know as much about this as me, but it's such a simple thing. Get the pulse oximeter on. If it's below 93, get them into hospital if that's what they want, and not everyone does. And you will make a big difference to your residents, but also your staff, because as we're doing with Sandra, Restore2 is a very enabling and actually, as the video said, actually gives you the power to go, I'm worried about this person. I might not be a clinician, but actually, we all understand sepsis and news scores. And whilst pulse oximetry at home and COVID is slightly different from, you don't have to do the whole news score, but nevertheless, if someone's got a 91, why would you phone me and go, and wait 20 minutes to speak to the GP? You guys know what to do. You're not going to get in trouble. You know your resident, get on and do the right thing. So that's a quick canter through. Any questions?
Thank you, Hein. I picked up one from, I picked up a couple from Sam about sourcing the pulse oximeters. I think you said you can get them from Amazon, but also do the CCG, do we know if the BNSSG CCG issue them?
We could put you in touch with, so I'm just thinking out loud here, Sandra Leroy, who's one of our colleagues at the Academic Health Science Network. We could put him in touch with you, and I'll do an email right now and put you in touch with the local provider and say, is there a stash of oximeters? In Gloucestershire, we've gone and given every care home setting, we've literally had thousands, and I don't know what they've done in BNSSG, but hopefully you've got an oximeter already. And if you haven't, the easiest thing, they cost about 15 quid on Amazon, and it's just such a good tool to have. It's like having a thermometer. Go on. Yeah.
Thank you.
Yeah, Husband House, fabulous.
Sandra, there was one question, another question that came up, which is about in terms of the Restore2 training, supporting staff to feel more confident in taking. Can you tell us a little bit about that?
Okay, because we're doing virtual training now, we've not been able to do face-to-face. Before the pandemic, we used to go into the homes and, I go in with my kids, we get people to have fun practicing on themselves. But of course, with the pandemic, we can't. So what we've done is we have a set of videos, and it's on YouTube. accessible to anybody. It's actually on the set of slides I used as well. So, people can watch that, in their own time, get together. It takes them through how to take every one of those observations. So it teaches you how to do the rest, blood pressure, pulse, and all that. But I mean, if you've got nurses in your team, nurses should be pretty good at this. Just get one of your nurses to show, the staff. They're actually easy because most of the equipment we use these days are electronic. Gone are those days when we do the manual, manual counts. Yeah. These days, just plug the thing in and it reads. Yeah.
Now, will you be able to send me the slides, please, and then we can get those on our website so that we've got all of the resources they need. If you could pop those over to me, that would be great. I'm not seeing any other questions.
From Osborne Court, someone's asked for me to send them the link to, get their staff registered. My plea, the real reason we came here is to obviously invite you to get your staff to come on the training. Absolutely. Because we want people to obviously use the tools. We want them to be able to, but they need to know how to use it. And unless they are trained, it will be unfair really to just say, there you go, get on with it. Yes. It won't happen. And the training is just for 90 minutes. So it's not going to take a lot of time. Even people who are shielding, can do it because it's virtual. Perfect. And it's fun. Yeah.
We like fun and we like quick.
Yeah.
That's great. Thank you so much. Anything?
One more thing, sorry, before I forget. Now, we've just set up, hi, Dom Care would need this meter on in every hour. Yep, okay. Jane, yes, we'll catch up with you. So we've just set up a care homes Facebook group. We're having the care home managers come into this group now. We're inviting you all to come into this group because this is a group that is set up to help you support each other, and we share lots of valuable information on that group. And people have really found it very useful. So I would also send you the link, Angela, if you can help me spread that out. Please do come in. You will find it really useful.
Thank you. Just going back to Jane's question about
dom care,
the dom care situation and using a pulse oximeter. I guess my question to add about that: how many times a day do you have to do it? Is it something that you have to? Sorry.
Hein.
Yeah. Normally I think it's trying to be pragmatic. So we do it twice a day. It literally takes 5 seconds to do. And in the morning, because the whole point is it's silent, so people don't go, oh, I feel unwell. So morning and evening. But then if someone feels unwell or anxious or there's something going on, and that might link back to the soft signs, just do the SATs because it might be that their SATs are dropping.
So in terms of dom care providers, what would they need to have one in every home, or could the care workers bring one with them and use it if they're doing a morning and evening visit?
Well, this is an interesting thing, and I know we're running out of time. Yeah, I would carry an oximeter and some sort of disinfectant wipes. Yeah. I get called by, and they do an amazing job and are an extension of our care homes in a way. And I get called by some people and they go, I'm worried about Mrs. X, and then they can't give you any more information and you have to visit. And then someone else will go, I've managed to do a blood pressure, a temperature, and a SATs and a pulse, which takes about 2 minutes to convert that into a news score. And then I can sit there and go, oh my gosh, I need to do this, or I need to do that, or I'll give antibiotics. So it's a massive help to us. So if the dom care colleagues could do some of this, that would be amazing.
Is that okay for you, Jane? Does that answer it for you?
Yeah, what I was thinking was perhaps that we could have a couple of care workers, perhaps on double ups, or a supervisor who could have this little kit ready to pop in if a care worker says Doreen's not great today, so we can pop in and do some stats. So that sounds good, that we can transport the equipment rather than have to have it in every home.
Yeah,
I I think we're all aware that, you know, say, oh, just do this and this, and how busy everyone is, and are the same. But I do think when these things are done and built into how we work, they actually save a whole lot. And the whole point is not to take half an hour doing a set of obs. You can do it to someone in
because
20
it doesn't.
seconds.
None of them take very long, and I totally get that, but we could, I'm just thinking about accessing that equipment, because sometimes we only visit somebody once a day. We don't want to buy that equipment to sit there when we could be utilising it elsewhere. So I think that would be really useful. And we are getting a little bit of help at the moment from the Infection Control Fund. So, you know, this is something that we could perhaps put together from that. So that would be really useful. That would be useful.
I think if you can decontaminate your equipment, you know, so long as you can safely decontaminate it, then you can transfer between.
Because we're not putting it in their mouths, are we?
No. Yeah, it's just a finger, but then it's proper, you know, decontamination, just clean well, and Yeah, no,
that's perfect. Yeah, lovely. Thank you. Yeah.
Thanks, Jane. Okay, I'm not seeing any more questions come up. Thank you, Sandra, for putting the link in for everybody to see. So our follow up from this is that you will send me the slides that we can get up on the website to enable people to go ahead and get the booking of their staff done on this training. So thank you from me on behalf of everybody on the call, and I suspect all those who are going to watch this on our website as well. Thank you, Sandra. Thank you, Hein, for a really, really interesting and helpful session. Actually, you know, we do helpful sessions and we do interesting sessions, but then we do sessions like this that actually go life-saving stuff. So
and you guys are amazing. So, you know, well done to you. All I can do is we take our hats off to all of you in the care setting. Thank you so much for your amazing work.
Thank you.
Thank you. And that really leads me just to my final sign off, to remind everybody that the Care and Support West annual care, I don't know what is wrong with my mouth this morning.
You need coffee.
For the Care Awards, please go ahead, go to our website while the nominations are still open, just for a few more days. Please nominate your staff. As Hein and Sandra and I know, and you know, there are people in your teams who really deserve being recognised this year of all years, not least you all as well. So thanks, everybody. And we'll see you again, hopefully on the 17th for the Care Under the Rainbow workshop. Thanks, everybody.
Thank you.
Thanks. Bye now.
Bye-bye.